My name is Dr. Siraj Gibani. I'm the director of the Spine Institute here at Casa, Colina, and I'm also with the Inland Neurosurgery Institute. And I wanted to just shed some light on the surgical aspect of spine management with regards to some of the terms that you may hear and some of the things that get mentioned. And I'd like to at least give some clarity to it and talk to you about when surgery becomes a potential treatment and the role for surgery, and what things you can potentially expect. So just briefly going back, spine surgery, really the goal of spine surgery is to take the pressure off of the nerves and or the spinal cord. This is often caused by different types of issues. Most commonly we see degenerative spine, which is really just chronic wear and tear of the spine that occurs with time and with age, and oftentimes repetitive movement. The other potential problems that can affect the spine are things such as trauma, tumors or cancers that afflict the spine, and congenital abnormalities for which people are born with. Certain conditions that may require spine surgery, and that terms that you may have heard are things such as spinal stenosis. Spinal stenosis refers to narrowing of the spinal canal where the nerves and or spinal cord are being pinched. Other things are the herniated disc. The disc, which is the soft cartilaginous portion of the spine that's located in between the bones, can often weaken and as a result push back towards the nerves, and that can require surgery. Spondylolisthesis refers to instability of the spine, where a segment is unstable and there's abnormal movement that results in pain as well as compression of the nerves. And scoliosis is just an abnormal curvature of the spine that can also lead to chronic back or leg issues. So surgical terms, some terms that you may hear when we're talking about surgery. The first one is a laminectomy. So laminectomy involves removing the back part of the spine known as the lamina. And what it's done for is to decompress the spinal cord and or the nerves. And what it's essentially doing is sparing the moving parts of the spine. So a question that's often asked is, well, don't I need the lamina? Isn't that an important structural part of my spine? And the short answer is that if it's causing a lot of problems, then it's not necessarily a structural structural support portion of your spine. And what we're doing is we're essentially sparing the moving parts of the spine, known as the facet joints. Now here in this diagram, we can see an example of what a laminectomy would involve. And here in this picture here on the top right, we're looking at the spine from the back. And what we're seeing here is the lamina, which is the back part of the spine that sort of serves as the roof over the spinal cord and or the nerves. And we can see here how that portion of the roof has been removed to decompress the spinal cord. And in this view on the bottom is a cross-sectional view where we can see when the spinal cord is compressed, we're able to take the lamina out in order to relieve the pressure on the spinal cord. Now, discectomy involves removing a part of the disc that is herniated or is pushing on the nerves. Oftentimes, the disc can weaken, and a portion of the inner part of the disc, known as the nucleus, can push out towards the nerves. And that can lead to symptoms that cause pain, numbness, or weakness in one limb. And as a result, surgery may be required, especially when conservative treatments have been attempted and have failed. And the understanding is that most of the disc is actually preserved, and we're actually only removing a part of the disc that is herniated and leaving the rest of it intact. And so here, this example shows us what happens when a disc is herniated. And we can see here the inner soft portion of the disc, known as the nucleus, has pushed back towards the nerve, causing inflammation and can lead to symptoms such as sciatica. And as a result, we go in there through a small opening in the lamina, and through that opening, we're able to remove that diseased part of the disc in order to relieve the pressure on the nerve. Now, Furaminotomy refers to opening up the space known as the foramen, which is the small opening where the nerves are exiting or leaving. And that could be similar to a laminectomy, just not as involved. Now, a spinal fusion is stabilizing a portion of the spine by placing hardware or instrumentation. The approaches for a spinal fusion can be several, including coming in from the front, from the side, or from the back. And oftentimes the approach is tailored to the type of pathology that's affecting the spine. And there are certainly advantages and disadvantages to either approach that I ask that you really speak to your surgeon about if they deem you a candidate for a spinal fusion. That's something that's often done. Now, instrumentation or fusion involves placing hardware to stabilize the spine. Now, that hardware can often involve screws that go into the spine from the back, and these screws are connected by interlocking rods. That can also involve removing the diseased disc and replacing it with a cage or a spacer in order to preserve the height. And that can also involve coming in from the front of the spine, as we see in this lower picture here, where we place a plate to stabilize it. Now, over time, the expectation is that the bones will grow across this space or across this area, and that's where the true bony fusion comes into place. Now, the question you may be asking is, well, I'm getting spine surgery, what's next? What do I need to do to make sure that I have the best chance of success from this surgery and have the most optimal outcome? First of all, you want to make sure that your general health is in good shape. So you should consult with your primary care. If you have a cardiologist or a pulmonologist, it's always important to consult with them as well, because you want to be in the best shape and the best condition to go into the surgery. And the better condition that you are going into the operation, the better condition you are coming out of it. The other thing is important is that if you do smoke, you should try and quit smoking. And I know that's easier said than done, but I can tell you without a doubt that smoking does negatively affect and impact spine health. And if you're an active smoker, then that can potentially affect your spine's ability to heal and recover after surgery. So it's very important to try and quit smoking. You know, you can certainly consult with your primary care physician about certain types of smoking cessation programs that are out there. Losing weight. Weight is very important when it comes to overall spine health, especially for the lower part of the spine, because the spine has to carry a large portion of the weight. And so when there's a lot of stress, a lot of pressure on the lower back, that can potentially affect recovery and healing after surgery. And so trying to lose weight coming into an operation makes it easier and facilitates both an easier surgery and an easier recovery. And reduce narcotic usage. Oftentimes, patients who are getting spine surgery are those who have chronic pain, and as a result are taking pain medications that will help to control the pain. The problem is that with very high narcotic usage, that can potentially affect someone's sensitivity to pain medications and can make it more challenging to control pain after surgery. And so it's very important to try as best as possible to reduce narcotic usage so that we're able to keep your pain under control after surgery and give you the best chance of success. Now, the steps that are involved with regards to surgery are often your preoperative consultation with your surgeon, where you're able to go through your symptoms as well as the imaging and talk about the best steps or the best approach to giving you a good chance of success. There's often blood work that's involved, as well as preoperative testing. This involves an EKG, a chest x-ray, and maybe other potential tests that your primary care or cardiologist may recommend. If you are taking any blood thinning medications, then you're often required to stop that blood thinning medication for a certain period of time, both before the surgery and afterward. And that can include medications such as the non-steroidal anti-inflammatory drugs, such as ibuprofen, Aleve, Motrin. That also includes other multivitamins and other supplements. DME. DME stands for durable medical equipment. Oftentimes with surgery, your surgeon will recommend that afterwards that you wear a sort of support device. This can involve a collar that goes around the neck or a brace that goes on your lower back. And so it helps to be able to arrange getting this type of equipment before surgery to give you the best chance of being able to get up and mobilize as quickly after the surgery as possible. This can also involve getting your room and your house ready for you after surgery. Certain things like, for example, if you have a bedroom on the second floor, it may facilitate to potentially try to make arrangements to be able to stay on the first floor. Certain things like having a bedside commode to make it easier to go to the bathroom. These are all things that you should really consult with your surgeon with regards to preparing yourself for the best chance of success after surgery. Thank you for your time, and at this point, we'll open it up to any questions that you may have.
Okay, thank you, Dr. Gibani. Joining us also is Ellen Moore, who's a physical therapist and a current member of the spine program team, and he will be moderating the question and answer session with Dr. Gibani.
Okay, thank you. All right, Dr. Gibani, we do have a few questions. First one, my MRI says I have several bulging discs. Will I eventually need surgery?
That's a good question. I'll repeat the question and just so everyone gets that. So the question is, my MRI shows that I have several bulging discs. Does this mean that I will eventually need surgery? The short answer to that question is no. Just having a bulging disc in of itself is not necessarily an indication for surgery. There are oftentimes other conservative treatments, as were previously discussed in previous seminars, such as physical therapy and other exercises that can really focus on strengthening the core, stretches for the lower back, that can prevent these bulging discs from getting significantly worse or affecting your spine health. Now, if the bulging discs are causing significant compression of the nerves or the spinal cord, then this may be an indication for surgery. But just merely having bulging discs alone does not necessarily mean that you will need surgery.
Okay. Do all patients who participate in the spine program end up having surgery?
That's a good question, so I'll repeat that. So the question is, do all patients participating in the spine program, will they eventually get surgery or need surgery? The answer is no, and I can in fact tell you that a very small portion of the patients who come through the spine program end up needing surgery. We pride ourselves in really taking the time to exhaust all conservative or non-surgical treatments for issues of the spine. And in fact, a very small proportion of patients do end up requiring spine surgery. As I mentioned, there are other conservative, non-surgical, less invasive treatments to treating ailments of the spine, such as physical therapy, such as pain management, and these are all steps that are often taken before someone is recommended to undergo surgery.
Okay, this one is a combination of two questions. How long does it take to recover from a back fusion? And can you also please comment on the loss of flexibility that goes on with this surgery?
Sure, that's a good question. Yeah, so question is, how long does it take to recover from a back fusion? And the second part was asking me to comment about the loss of flexibility after a spinal fusion. Two very good questions. So the first question is kind of a loaded question. It certainly depends on the type of fusion as well as the number of levels that are fused. Typical recovery time from a spinal fusion is anywhere from 3 to 6 months. And that's really, allowing the spine to heal after a spinal fusion. As I had mentioned earlier in the presentation, when we do place hardware or instrumentation in the spine, what we expect to see over time is that the bones will actually grow across that space. And so what happens is when you do have a spinal fusion, your surgeon will often get radiologic imaging periodically to inspect or look at the fusion and make sure that everything appears to be healing properly. Now that process can take anywhere from 6 months to a year, depending of course on certain factors such as your age and other potential factors that may affect healing. But the short answer is that typical recovery from a spinal fusion is in the ballpark of about 3 to 6 months. And I always tell patients that by about 3 months is when you're really going to start feeling more like yourself. And at that point, that's when we try to really push you to do more exercise, more activities to try to strengthen your muscles and get back to sort of a more normal lifestyle. And then usually by 6 months, of course, like I said, it really varies on the type of fusion, but that's when we sort of release you and let you do everything. The second part of the question was asking me to comment about the loss of flexibility. That's often a good question and a question that I commonly encounter. Now, if we're just fusing, for example, one level only, the loss of flexibility is really not going to be noticeable. And the reason why is because you have movement across every single level or every single segment in your spine. And so when we're fusing one level, the rest of the motion in the spine is preserved. And a lot of the motion as far as twisting and turning and bending is not only within the spine itself, but it's distributed amongst the other joints, such as the hip joints. And so fusing one level only really won't lead to a significant loss of motion or mobility. Now that can certainly vary depending on which level is fused. For example, if we're fusing, towards the top of the neck, where a lot of your neck movement is located, that can impact mobility. But most areas where we typically do the fusion, whether it's in the lower neck or whether it's in the back, doesn't significantly affect mobility. Oftentimes the reason to do the fusion is because of too much motion or too much mobility within the spine that's causing pain or causing symptoms.
Okay, and then since we're on the topic of fusion, I have a question coming in that is the hardware ultimately removed?
The question is the hardware after a fusion ultimately removed? The answer to that is typically not. There are very rare circumstances where we do remove hardware, but most of the time when hardware is placed and implanted, that hardware stays in there permanently. Now the hardware is safe. Most hardware placed nowadays is made from titanium, and oftentimes there's a combination of other materials that are used. The material is safe, meaning it's not rejected by the body. It doesn't set off any metal detectors. That's a question that I often encounter, and it's still MRI safe or MRI compatible. There are certainly rare indications for going in and removing hardware or replacing hardware if a spinal fusion, for example, has failed, or if there is a case of an infection, but typically hardware is not removed.
Okay. The question is, what is spinal instability?
Spinal instability really focuses on the abnormal movement within a segment of the spine. Early in the presentation, I spoke about a term called spondylolisthesis. Spondylolisthesis is actual slippage or movement of a segment of the spine. The layman's term is a slipped disc. And when that happens, spinal instability in of itself can cause pain. And not only that, but the nerves and or spinal cord can be compressed as a result. And in order to treat that, a spinal fusion must be done to take care of that instability, to stop the abnormal motion in that segment and get rid of the symptoms.
Okay, and that leads to this question. If my doctor says my x-ray shows a spondylolisthesis, will this mean that I will need surgery?
The question was, if an x-ray shows spondylolisthesis, is this something that will eventually need surgery? The short answer is not necessarily. It certainly depends on the type of symptoms that are associated with that. I often tell my patients, I'll show them their films, whether it's their MRI, their x-rays, or their CT scan, and I tell them that I'm not treating the images, I'm not treating the pictures, I'm treating you as a patient. And so if there are symptoms that are attributable to that spondylolisthesis, then certainly that can be an indication for surgery. But the spondylolisthesis by itself is not necessarily an indication for surgery. There are a lot of people out there who live with spondylolisthesis who don't have any symptoms or very little symptoms, and as a result don't need surgery.
Okay. And then where do you perform your surgeries?
Yeah, that's a good question. Well, here at Casa Colina, which is where our spine program is based, is where we do a large portion of our surgeries. We have a phenomenal operating room with state-of-the-art technology. We have a great program both in the intensive care unit as well as on the med-surg floor. And so we certainly do a large portion of our surgeries here at this hospital.
And another question is, I've already had spine surgery, but I'm still in pain. I'm reluctant to have surgery again. What are other options to help with the pain?
That's a good question. So the question is someone who's already had spine surgery and is still having a lot of pain and really looking at other options. And I can certainly understand your reluctance, having already gone through that process once before and not having to, not wanting to go through it again. The question, I think, really boils down to what is the cause of the pain? Was the surgery that was done initially enough to address the source of the pain, or maybe was there another potential cause of the pain that just unfortunately wasn't properly diagnosed? I think that that's really important question to answer, and that's why we take pride here at the Spine Institute of taking a sort of a multidisciplinary approach between myself on the surgery side, as well as with pain management with Dr. Carlos Martinez and Dr. Alan Huang and Dr. Sam Neal with the physical medicine and rehabilitation side, really to be able to take a comprehensive approach to the spine and specifically to any ailments or issues of the spine in order to properly diagnose the problem and find the proper treatment. I think, the short answer is that, you don't necessarily need another operation or another surgery, but that would really involve a proper assessment of the type of pain that you're experiencing, and really looking at, your symptoms as well as any associated imaging to help come up with the answer.
Okay, another question is, will I be required to do physical therapy as part of the spine program?
It depends on your condition. We do strongly encourage most patients to undergo physical therapy prior to going through more invasive treatments. Now, there are certain conditions that we classify as red flag conditions where when there is significant compression of the spinal cord or nerves that is causing or affecting neurologic function, then sometimes in those situations, we don't want to wait until you lose further function before doing the surgery. So in those situations, then we maybe speed up the process as far as getting surgery. However, most patients do benefit from physical therapy. If anything, it actually prepares you for after your operation or after surgery or after any other treatment that you may get to help you better take care of yourself and better take care of your body. So not everyone is necessarily going to get physical therapy, but I would say that a large portion of people do benefit from it. You really need to be able to take the time and the effort to take care of yourself and take care of your body in order to have long-term success, whether you have surgery or not.
Okay. Question here is, my husband has spinal stenosis and has been told he may need back surgery because his legs go numb when he walks, or his legs go numb when he walks. What surgery would most likely be done? And what would be the recovery time?
Yeah, sure. So, the condition that's being described as far as spinal stenosis that's leading to numbness in the legs when walking is known as neurogenic claudication. And neurogenic claudication is often a result of spinal stenosis where there is compression of the nerves, and that leads to pain, numbness, or sometimes weakness that can be associated with activity and oftentimes improves with rest. Now, if there is actual spinal stenosis and other conservative treatments haven't worked, then surgery would be an indication. It sounds like, based on what I'm hearing, this is likely going to be something that would be treated with a simple laminectomy. A laminectomy, as was described earlier in the presentation, involves removing part of the lamina, or the part that houses the spinal cord and the nerve roots, and to create more space or more room. Now, oftentimes with the laminectomy, depending on how many levels are treated, this can be actually done as an outpatient surgery, meaning that you get the surgery and you're able to go home the same day. If anything, it may require an overnight stay in the hospital, and then you're able to go home the next day.
Okay, that's it.
All right. Once again, thank you, Dr. Gibani, Alan, and everyone who joined us tonight. If you have additional questions that were not answered or would like some additional information on the spine program, please contact us at the number that you see on the screen. Also, if you missed one of the previous webinars from this series, please visit our YouTube page as we will be posting the complete series on our page in the coming days. Have a good evening. Thank you.
Thank you.